Hi everyone, welcome to today's student-led journal club seminar. My name is Anne-Marie Hayes. I'm a research associate on the Joplin campus for KCU. Today I'll be introducing our speaker, student Dr. Donald Keating. Student Dr. Keating received his bachelor's degree in health and exercise science from Oral Roberts University and is now a second-year medical student at Kansas City University on scholarship through the United States Air Force. Student Dr. Keating's previous research work is in the field of chronobiology, physical activity, biometrics, and lifestyle psychology. After concluding his first year of medical school, he went to Stanford University for an intensive 8-week research internship with the Department of Otolaryngology, head and neck surgery. Student Dr. Keating's current specialty interests are otolaryngology and neurology. So with that, the floor is yours.
Thank you. Thanks for having me today. I'm happy to be here. And like she mentioned, I previously, over this past summer, was involved with the Department of Otolaryngology at Stanford, working on some episodic dizziness and vertigo projects. And so I'm excited to talk about that with you guys today. The project is still ongoing. It's a biotech project with a device that's monitoring the attacks. But before I get started with that, I do want to say thank you to, the team on the left from Stanford who I'm working with, especially Dr. Peter Santamaria and Dr. Kristen Steenerson. They both have been incredible mentors to me in the fields of both otoneurology and neuro-otology. Brad and Dan are the engineers on the project, and Steve helps with the operations and the legal side with the contracts. But I also want to say thank you to Dr. Holt and Dr. Sine. Dr. Holt is faculty at University of Texas, San Antonio, but he's also adjunct professor with the bioethics department at Kansas City University with us. Both him and Dr. Sine were very instrumental in helping connect me with resources when I was out in California this summer. So I'm very grateful for them. And with that, I'll show you a little bit of a roadmap of where we're going. We're going to talk about an overview of episodic dizziness, as well as the current vestibular testing for patients who are dealing with episodic dizziness. And then we're going to go into talking about this project that I've been working on, this new diagnostic concept for monitoring dizzy episodes. And so just to begin with an overview, there's mainly 4 types of dizziness. The first one is just a pre-syncope, which is more of a lightheadedness, generally caused by low blood pressure or orthostatic hypotension, typically leads to syncope as in the name. Another type of dizziness is disequilibrium, which is more of a wobbly feeling, or like it says, feeling off balance. This is mainly goes away actually when you sit down. It's kind of a distinct factor of it. It's commonly associated with more cerebellar dysfunction. Then there's more of a catch-all, a non-specific feeling funny. Ignore that, this right there. But this is a swimming or floating sensation, often more associated with disassociation. And for our talk today, what I'm going to be focusing on is more vertigo, which is this spinning or this illusion of movement, such as tilting, floating, impulsion. Can cause inner ear disturbance or more centrally with a brain disturbance. The main thing to focus on with vertigo is that it's this illusion of movement. And within vertigo is where we see the majority of the episodic recurrent dizziness. So pre-syncope, disequilibrium, non-specific dizziness, those are more one-time dizziness causes, whereas we see mainly the recurrent debilitating vertigo as more of the episodic side of things, and more with that is on the vestibular side than with the central side. So just an overview of the vestibular system, it's part of the inner ear, sends information about head motion and orientation. This is done with cranial nerve A, vestibulocochlear nerve, to the cerebellum to help coordinate balance, gaze stability using eye movements and head movements, gait stability, helping keep you upright with those stretch receptors, and spatial orientation, which just maintaining that sense of equilibrium where you are. So all this is used to help with your equilibrium and balance system. And really any dysfunction throughout this system can produce some of those causes of dizziness that we just previously talked about, but we mainly see the recurrent dizzy episodes produced within, right there with the star, the vestibular organs. And so within these vestibular organs, we can also classify now down more to an overview of vestibular causes of dizziness. And this is just a long laundry list of the different vestibular disorders that can cause dizziness. And for our talk today, we're going to focus on the top portion, the episodic vestibular syndromes. And of these, we're going to narrow it down to the three most common causes of recurrent episodic dizziness, which are BPPV, which is benign paroxysmal positional vertigo. This is when you have tiny calcium little like crystals. They're called otoconia that come loose in their normal location from the utricle, and they go into those semicircular canals and produce that illusion of movement. This is typically dizziness that lasts for seconds to minute at the most. And there is treatment for it, but even the common Dix-Hallpike that we've learned so far in med school, and that and most physicians understand, it's not always done properly, and a lot of times BPPV can continue on as episodic vertigo because it wasn't tested for properly. Meniere's disease is another very common cause of episodic dizziness. This is more of an excess endolymph buildup in the labyrinth, interferes with balance and hearing signals, and vestibular migraine, which is a newer term in terms of how long dizziness has been talked about and researched on. Vestibular migraine also can be misdiagnosed commonly because patients don't associate migraine with their dizziness. When people think of migraine, they think of headache, having to go to a dark room and close your eyes. But a lot of times with vestibular migraine, it's not always associated with a headache and is more accurately described as a overstimulation or oversensation of the brain. And these you can see last for longer. These can be, or they can last up to longer experience, like days, but they can also be minutes long. So you can see how someone who's having dizzy episodes that are minutes long, 30 minutes, let's say, they kind of overlap in different ways. And that's part of what I'm trying to display with this chart, is that although this chart makes it seem as though these vestibular disorders are so separate and so different from one another, the reality is that they're quite similar and can overlap depending on what vestibular testing was being done and how the patient is presenting. There was actually an interesting study that looked at this. They looked at the interrelations between different causes of dizziness, this specifically looking at the vestibular disorders. And in the conclusion here was a phenomenal sentence, I thought, that said, a detailed review of the literature supports the hypothesis that vestibular disorders exist in an incompletely understood web of interconnected relationships. And so that's the main takeaway I want to get at with by going through these different disorders of episodic recurrent dizziness and vertigo, is that one of the difficulties is that it's not completely understood, and it's this web of interconnectedness that we don't fully understand right now. And so as physicians, if it's not being completely understood of how the patient's presenting, you can only imagine how much more difficult that is to actually be the patient dealing with this. And I thought this was incredible timing because a study actually came out yesterday talking about the economic impact specifically of recurrent dizziness. This was published in JAMA. It was done by the Medical University of South Carolina. And they looked at Meniere's disease, vestibular migraine, and BPPV, which we just talked about, the three major causes of episodic dizziness and vertigo. And they looked at the considerable medical costs associated with them. And what they found was that between $2,000 to $5,000 per person per year compared with the normal population was the cost for patients dealing with episodic vertigo and dizziness. And what that amounts to is a total annual increase in cost to society of $60 billion. So you can see there's this insane economic factor with these vestibular orders that are causing episodic recurrent dizziness. And a lot of that has to do with the extraneous imaging orders and testing that's being done. And we'll get into more of the testing in a bit here. But part of the issue is all the testing is dependent on being done in the clinic. And so when you're only able to receive diagnostic images and data from when a patient comes in, you tend to do more because there's not as much information of what's going on with their dizziness at the time. And so 2 years ago, when this project started, was when this idea kind of happened of, okay, how do the patients who are dealing with the episodic vertigo and the episodic dizziness and these vestibular disorders, how are they feeling about this? And so 2 years ago is when the idea for the device came about, and I'll be talking about the device here shortly. But I want to first look at the patient experience of actually dealing with these disorders. And so a survey was done, and that was part of what I was a part of over the summer, was looking at this survey and just looking at the objectives of what the survey was. We were looking at just assessing the current practices for dizzy attacks, quantifying the new diagnostic concept that we have, as well as measuring sensitivity to pricing and accuracy. And this is a little bit of the patient population that we had, just 250 individuals, and how we categorize them was based on the frequency of their attacks. So we were mainly interested in the daily and the weekly attacks because that's a little bit more recurrent and episodic in nature. But we also wanted to gather information about monthly and infrequent attacks to just get an encompassing number for all. And so the first question that was of interest was, okay, how do these patients actually feel about their attacks? And so the primary concerns, we kind of lumped it into this illustration here, was that falling, hurting themselves, being afraid, passing out. And I have some quotes from these patients, just being able to function without any issues and not having to have any fear that these dizzy attacks are going to occur when there's nothing nearby to grab onto or steady themselves against. Just getting it under control and not falling or having any accidents. Safety is number one concern. Decline in ability to remain autonomous is also a concern, as well as what causes them. What can I do to stop them? These are coming straight from the patients who are dealing with these episodic vertigo attacks. And you can see that this isn't just a feeling of standing up too fast and being lightheaded for a minute or two. These are patients that have debilitating, life-altering dizziness that is continually going on from day to day or week to week. And they're frustrated with not having, whether it's a diagnosis or not having treatment that's working, or just no clarity on what's actually going on. And so we then ask, okay, what types of clinicians are actually seeing these patients? Who's being seen? And what we saw is they're being seen by a variety of doctors: primary care, neurologists, ENT, cardiologists, physical therapists, and audiologists. And part of this widespread for this is just the fact that there's so many different causes of dizziness, as we kind of briefly talked about, those 4 different causes that might grant a conversation with a cardiologist or a physical exam with a cardiologist or physical therapy, vestibular physical therapy specifically. But you can see, if you look at these weekly and daily attacks, how high some of these percentages are for seeing specialists across the board. And so then we also asked about, okay, well, if they're seeing this many different clinicians and providers, well, what tests are being done on these patients, and how satisfied are these patients with the tests that are actually being done? And so we have this data here of the responses from these patients. And again, it's grouped by frequency of attacks. And you can see just the low satisfaction rates that patients have with the tools that they've been offered to diagnose and understand their dizzy attacks. that when you see just overall 33% are satisfied. But when you look even just at that weekly number, 27% are satisfied. That again, these are patients dealing with episodic vertigo attacks, and with the the gold standard of testing using vestibular testing, physical exam, MRI, CT, audio exams, it's not satisfying to patients, which mainly is probably because of they're not seeing the outcomes that they're actually looking for. But just to go over a few of these important tests that are done, the gold standard is going to be a VNG, which stands for Videonystagmography. It's a test that measures, uses ocular movements, position movements, caloric movements to measure types of involuntary eye movements, such as nystagmus and saccades. Calorics will check for the function of that vestibular cochlear nerve. And similar to a VNG, we have something called an ENG, which is Electronystagmography, which measures very similar things, but does not have that infrared camera capability. And this is more monitoring electrical impulses with those extraocular eye muscle contractions. But as we saw, patients were dissatisfied with the testing that's being done. But the question is, okay, well, how helpful are these tests for diagnosing these patients? And this is where we see a dramatic number of 60% of patients are still not actually even diagnosed with a vestibular disorder. And we talked about BPPV, vestibular migraine Meniere's disease. These are the three most common causes of episodic dizziness. And these patients are all dealing with episodic dizziness, but none of them are being actually diagnosed with one of these three, which goes back to show how interconnected things can be and how difficult to actually diagnose these disorders. And so just a little bit of a recap of that data that we looked at. The frequency of the dizzy attacks was associated with the increased testing. So the more attacks you were having, the more likely you were to have more tests. And the in-person dependency of these tests, all the VNG, the ENG, MRI, CT, of course, obviously all of those are done in the clinic, and patients aren't always having an episode of vertigo or of dizziness at the time when they're with their doctor. And so that goes back to that study that was just published yesterday that I mentioned about the extraneous imaging that's being done, mainly probably because these patients aren't getting diagnosed and physicians are trying to figure out what's actually going on. And it's just a reminder that these patients have lost functional capability to really do life how they once did. I had the privilege to be in the clinic this past summer with a lot of these patients, and they're being seen by numerous doctors having tests done, but still not being diagnosed. And so with all of the diagnostic tests being limited to in-office dependency is really where this idea was created. And this idea was, okay, is there a way to monitor these vestibular functions similar to an ENG or VNG, but do this outside of the clinic? And the whole goal for doing this would be, okay, can we find a way to speed up the diagnosis for these patients? This isn't a therapeutic device to make their vertigo or their episodes go away, but this is an opportunity to provide more data on what's going on when an episode is happening. And so this is the exciting part where I get to talk and introduce you guys to this project that I've been a part of, which is called Dizzy Diagnose. It's a take-home device that can record a patient's vertigo attack outside of the clinic. This device can be worn by the patient for up to 2 weeks and ideally potentially a month, and can help determine, okay, what's the cause of the patient's dizzy attack without requiring multiple medical appointments that we saw with multiple different professionals and providers, and without that extraneous imaging demand that we're seeing with these patients. And if you're limiting the amount of imaging that you're getting done with the patients, it's going to be less of a financial burden for patients who are dealing with these concerns. So how it works is similar to an ENG. In fact, I think it's easiest to call it a wearable ENG. It measures those extraocular eye movements And this is able to be done during and around a dizzy attack. And the idea is to take that data and then combine it with machine learning algorithms to help predict what attacks are happening and speed up diagnosis. So this is another image of what it would look like. Ideally, this aesthetic appeal where it's not something too embarrassing to have on your face. You don't have crazy wires coming out or a helmet that you have to put on. This is something that is subtle enough that people can be confident wearing for a short period of time. And it works with just 3 electrodes. That's enough to monitor the extraocular eye movements. And that can then be, like the previous slide mentioned, just combined with the machine learning and algorithms to help identify, okay, what's happening before an attack and after attack with those vestibular ocular reflexes, which can help determine, okay, what's the root of this dizziness cause, or at least provide more information to the clinicians as to, okay, what kind of direction with treatment do we want to take. The idea would be to also have eventually potentially just biosensors as well, such as, you know, a heart rate monitor or temperature monitor, different things of that. So I think the capability with it is endless. And so you are maybe thinking, at least I was when I first heard about this, was, okay, why has no one ever done this before, or is there any competition that's out there? And there is here on the third line something called Cava. They had a similar idea, but the problem was theirs wasn't portable, it wasn't wearable, and users were not very acceptable of it because of the bulkiness that was involved with it. And so when you can see when asked about ours, patients, it passed with everything that we were curious about, of the out of office ability, wearable, user acceptable. The data is easy to interpret for a physician, as well as it's portable and is accurate. I think that's one of the other things here, is it actually is accurate as to what's going on. And that goes kind of with, okay, well, what's the technical risk of this project? And when we compare it to the gold standard of BNG testing, well, it actually outperformed it. So you're not actually losing any accuracy with this. In fact, you're getting potentially even clearer data as to what's going on. And this is one of the engineers on the project. You can see it doesn't look like the Band-Aid that was in the previous slide. It's still very early on, but even just with that box of engineering work that's put over the eyebrow, it's able to perform to above the gold standard, and to the level where this is a very promising device to continue on forward with. But I think I can talk about it right now and say how special it is. But more importantly, when we ask the patients, what are the patients saying about it? How interested are they in? And so when we ask them to indicate, okay, what do you agree or disagree with the statements in regard to the Dizzy Diagnose project, how many are interested? And you can see even over half of the infrequent attacks are interested in putting something on their face to try and get a better idea of what's going on. But obviously, when you look forward and down as the frequency increases, you see that number continue to increase to where these patients with daily and weekly attacks, a high percent of them are very interested in trying this device. And so we see, okay, there's a higher likeliness to try this WENG, this wearable device, based on the increase of frequency of their attacks. We also asked about, okay, where would you be interested? Would you wear this when you're at home? Would you wear this while you're shopping, around coworkers, when on TV? And we saw that the more frequent patients were having their dizzy attacks, the more interested and willing they were to wear this device in various different environments. Even on TV, I thought that one was interesting, that people would be willing to have something on their face even while they're on TV. And when we showed them this picture of the electrical box on the forehead, we saw that the patients who were dealing with daily attacks were willing to sacrifice the aesthetic appeal to have a device available right now for them to use, even if it didn't look as pretty or just looked like the image on the slide here, which I think just goes to show how much of a need there is for more testing to be done for these patients and in this recurrent dizziness field. And I have a few quotes just of what patients are saying about this, which is, okay, it sounds new, innovative, potentially very useful. Not only that, but the design sounds very practical as well. It's a pretty good idea. I've heard of heart monitors. I've used heart monitors, so why not this? I appreciated someone saying this because that's a very close example that we use too of just a Holter monitor. It's similar to a Holter monitor, but for vertigo. And so the fact that someone mentioned that I thought was interesting. And someone also saying I would certainly try it because it seems safe to use and may help to find out why my attacks are happening. And I kind of put a little highlight there because that's the whole idea behind this is we're trying to provide more information as to why the attacks are happening so that clinicians and providers can have a more accurate idea and speed up care for these patients. And so what does it look like now? What is going on with it as we talk now? Well, this is a picture of me over the summer with the device. That's what it looks like right now. I'm wearing it on my forehead, testing out the user instructions for it. But one of the reasons that I think people have responded so highly and patients that are who we're making this for have been so open to using this is just because of that this is designed for patients and providers. It's universal and comfortable. We've evaluated the fit and the comfort through looking at what literature says and user tests and just different fit evaluations. But even though it's universal and comfortable, it's also very robust and durable. Just with the engineers that have worked on it to make it water resistant, to make it be able to monitor for 2 weeks at a time and potentially longer. We've co-developed it with manufacturing partners who are just very helpful in kind of filling in some of the gaps that we have in getting a product that is that has integrity and something that is going to make patients confident using. The other thing
Dr.
that
Keating.
Yes.
I see Dr. Johnston has raised his hand. Dr. J.
Oh, I'm so sorry about that. I do not see that.
Okay.
Yes,
It's my job to monitor.
Now, if it's appropriate to ask right now versus I can wait.
No, go
ahead.
for it.
Okay. Well, from what you've presented so far, Don, my question to you is twofold. You are with the use of this wearable ENG, it allows you to confirm what the patient is basically saying, that I've got a real problem here with my dizziness. My question to you is, when you say it measures eye movements, are we talking purely nystagmus, or what are we talking when it says measuring eye movements?
Yes, that's a good question. It's measuring, like you alluded to, the vestibular ocular reflexes. So it's looking at smooth pursuit, saccades, nystagmus, various nystagmuses. It's monitoring in the same way that an ENG would when you connect those electrodes there. I don't have a chart of what it would look like, but it's the same data that comes from our device that you would get from an ENG that you do in the office.
Okay, so then does that allow you to proceed by saying this is a peripheral problem versus a central problem?
Definitely.
Okay.
And I think even more detailed than that, for instance, Dr. Steenerson, who I mentioned previously, she focuses specifically on dizzy attacks. She has a neurology background. And so for someone like her, who's very experienced in looking and reading at ENGs and BNGs, even more specifically than comparing between central and peripheral, it can help just having that data of when an attack is happening to distinguish between various peripheral causes of episodic dizziness.
Okay, then my last component is, does this help you to include or exclude endolymphatic problems in the year?
Does it help include or with
Does
the
exclude it, or does it narrow it down to an endolymphatic problem within the?
it wouldn't necessarily narrow it down just to that one problem, but to my understanding, it would be helpful in depending on what the data is showing from the device, the wearable device, it would help give a closer idea of whether it is or isn't endolymphatic.
Okay.
I think,
Okay,
but the actual specifics of that, I'm unsure.
that's okay. Thank you very much.
Of course. Alrighty, so I will continue here. Just talking about this product is designed for patients and providers, looking at the universal comfortability of it. It's robust and durable. It's co-developed with different manufacturing partners, and as well as just the user experience of it. We included just the UI, the UX, and the human factors, looking, okay, what does a patient who's dealing with this, what would they be looking for from the actual product side of view? And I have a little bit of background with user interface and user interaction. So part of what I worked on this summer and actually I'm still working on, you'll see because it's unfinished, but the actual manual that patients are going to be using as we start our first clinical trial later this month. So how does this manual work? And at the same time of going through this manual, I can show you how the device is meant to work as well. And so what this is can't portray it as well on the screen. So I just included an animation of this brochure of what it's going to look like. So as we go through these pages, you can envision just a small, like quarter-size paper that would come in the box when you open it up. And so this is just the idea is that you'll be given this box at home with your physician with the device inside. You'll open it up and you'll be introduced to the device and how to put it on and going through patient instructions, daily attack instructions, this button press log that we have, as well as FAQs. And so the idea is, okay, create an instruction manual that is friendly, usability for people of all ages. I think that was something that was really important when I was thinking about this, was the majority of people who are dealing with episodic dizziness are going to be in their 40s, 50s, and 60s. And we want to create something that is easy to understand, not too complicated, and as well as use images to help clarify what is being said. And so you can see, you'll put the device on, you'll wash the side of the face that you're going to put it on. And then you're going to apply just a 3M adhesive. And this is for, I should clarify, this is for the current device that we have now, not the end product, but just the device that we're working on now. Because obviously this is a lot more on the face than what we eventually want to get to. So you apply the adhesives in 3 separate locations. Believe it or not, it's not actually as important to the location completely. There is a lot of room for error, but what's most important is just that second and third patch, which is where the electrodes will go, are parallel, and that allows us to measure both those vertical eye movements and horizontal eye movements. So you'll put those on and then connect the device to your face, and you'll squeeze the button on it and a green light will appear. And at that moment, the device will be monitoring. So at all times, the device is actually monitoring and collecting that data. But what we'll see is that when an attack is actually happening is when you'll actually squeeze the button again to notify this monitor that an attack is happening. What that does is it adds a timestamp for when the attack is. So when going back through the data, you can see, okay, this is when the attack was happening. This is what was going on before. This is what was going on after. And as I had previously said, this isn't a therapeutic device, so you'll just continue responding to your attack how you typically do. But the idea is for this to then be sent on afterwards, after your trial's over, to provide valuable information on the diagnostics of what's going on. We also include this dizzy button log. As I mentioned, this is still in the works, so you'll see at the bottom, I have exercising 3 times, but that was just as a filler for the time being. But the goal of this is that, again, you're not with your doctor at the time of your dizzy attack. And so we all know we can forget things or misunderstand what was actually going on at the time. So as long as having this data of the actual device, we can compare it to what the patient actually said was going on when the button was pressed. And then you'll remove the monitor after the dizzy attack or at the end of your 2 weeks, and you'll ship it back to your doctor. You'll take it to the doctor who had prescribed it in the first place, and the doctor will look at it, the information, and schedule up a follow-up appointment and go over the data with you and help clarify and reassure and validate what's actually going on with your episodic dizziness. These are just some frequently asked questions. It is actually going to be ideally waterproof in the future, just because we want to have the opportunity to gather that data at any part of the day. And the charging capabilities of it as well are still being worked on, but the idea is to not have to charge it at all, so that even when you're sleeping, that data is being collected for people who wake up with a vestibular migraine or wake up having a dizzy attack. And so that's the end of the manual. I did have the opportunity 3 weeks ago to be at the Academy Conference for Otolaryngology in Philadelphia, and got to display this poster about the device at an entrepreneurship event going on during the conference. This is myself with Dr. Santa Maria, who I had mentioned to earlier. He is in charge of the lab and the one who really had this idea in the first place to begin with. So I'm really grateful to him and for this opportunity to present it. And then again, I'm thankful for this group of incredible people who've helped this project come to light, and as well as the faculty from our school and Dr. Holt, who helped get me involved over the summer. And with that kind of wraps up the presentation that I had, but I'm definitely open to any questions if anyone has any.
Awesome. Thank you so much, student Dr. Keating. Great
Thank you.
presentation. As he said, if anybody has any questions, feel free to raise your hand in Zoom, or if you can't, type it in the chat. I see Dr. Talley, you have your hand up.
Yeah, I was, thank you for the wonderful presentation, Donald. It was very, very well done. The thing that occurred to me that is incredibly important about this is it was one little sentence you did, and that is that it increases the possibility to maintain independence, which is hugely important as people age and become less stable. So I think this is really an important device. How far is it from actually being on the market?
It's hard to say, and I feel like things never go according to the timeline that we have in mind. But we're excited to start looking at patient data and going from there to continue developing the prototype into the device that we're happy with, and that will be both accurate, similar to those things I mentioned previously, but comfortable, robust, accurate, but also something that patients are going to be okay with having on their face. So that's what we're working with manufacturers to help develop that. So it's hard to say at this point, but hopefully sooner than later.
Good.
Dr. Archer, you have your hand up.
Yeah, thank you so much. Very interesting. Do you have any sense of what the possible cost for having this device for 2 weeks and analyzing it, reading it, all of that? What's the actual cost going to be for this device?
I don't think that we have a ideal cost at this time. I think it, for one, goes to see if it can get reimbursed or not. But we did ask patients how much they were willing to pay out of pocket for something like this, which brings up a interesting question, because a lot of patients weren't willing to go over $70 for something like this. I think the most that we saw was a couple hundred or something. But it's interesting. Okay, you fill out this survey information about how terrible of a quality of life you're having with these dizzy attacks, and then a device comes along that we say, hey, if this will be the solution to your vertigo, how much will you pay for it? And then a lot of people saying, oh, $40, $50. So I think the pricing still, and maybe just education around the cost with it, there's still work to be done there. But that's kind of where things are at with the pricing.
So as a follow-up question, when you look at those most common causes, I've not looked at the literature recently to see for each of those, how effective is the treatment? And then what's that cost of the treatment?
Mm-hmm.
And then you start thinking about, well, you know, is it as reasonable to just say, okay, let's rule out this by doing the treatment, and if they get
Right.
better, then we know what it was.
Mm-hmm.
And then if that doesn't work, we go to the second most likely cause and try that treatment.
Right.
So I'm just trying to get a,
Mm-hmm.
and also what to do in the interim if this isn't available. Is that in some ways a more realistic approach than multiple office visits when they're not actually having the episodes at that time, and you can't do an accurate test anyway? So you're basically testing by treating.
Right. No, it's a very good question, and I've had I had a similar thought, and that's why when I put those 3 disorders up, I made the point to say these seem so different from each other, and the treatments are different. With BPPV, you're going to do a Dix-Hallpike. Typically with Meniere's disease, it's typically surgery, and vestibular migraine, it's going to be medication. So to your point, okay, why don't we just then do it all and fix them? It doesn't matter if we know which one it was. Now they're feeling better. But I think that what is becoming more recognized is that it goes with that line of just the interconnectedness between them all. And I think it's vestibular migraine and Meniere's disease that they're so similar that actually a lot of the treatment plan is similar for both of them, but patients are still not actually getting better. And so there's this room for work to be done on the epidemiology with recurrent dizziness, because it is unclear as to really what's going on. And the treatments for textbook Meniere's disease isn't actually helping everyone who has Meniere's disease. So there must be something else that's going on. And we can only see what's going on neurologically when we're doing testing, which is done in office, and patients are paying for that. And so hence the extraneous imaging and things of that sort. And so I think that's where there's room for something to be done like this device where, okay, let's actually get more information of what's going on while the attack is happening.
Yeah, I mean, there are certainly examples with psychiatric illnesses where if your diagnosis isn't correct or specific enough, then the treatment may be failing because of that, or they may actually have, you know, 2 things going on, and you're only treating one of them at a time. So interesting. What so with those, not counting Meniere's, but with the other conditions, what is the success rate of treatment if we actually think that's the right diagnosis? If you've got, you know, and that may be part of what this is worth doing, is it will help refine or narrow the field so that you actually then know if you have enough power to detect a positive effect from the treatment.
You're saying what is the success rate of the treatments for those? I don't know the percentages off the top of my head, but I know BPPV can be very finicky because it kind of depends on that otoconia that's in those canals. And for some people, one Dix-Hallpike will cure them. They'll walk out of the doctor's office completely fine and potentially never have to come back. It's number one cause for dizziness in that's being seen in the clinic. But for some people, for instance, I saw this summer with Dr. Steenerson, they would come in to be treated for their BPPV, or at least diagnosed with BPPV. And then we would do 1, 2, potentially 3, depending how the person's doing, Dix-Hallpikes to try and move that otoconia. But they'll have to then go and do more of that with vestibular therapy for however long it takes. So I know there's been studies done. I don't know the percent of success rate. I think it also depends on what canal that the otoconia is in. And with vestibular migraine, I actually do not know the success rate either for that. And I think part of that is because it's still being developed as to really what does someone with vestibular migraine look like and present as, and what is the best way to treat that specifically that person with vestibular migraine, or is it more of a personalized treatment considering the symptoms that they have?
Thank you.
Mm-hmm. Thank you for the questions, everyone. Does anyone else have any more?
Thank you so much,
Awesome.
Dr. Keating. That was again a great presentation. Great job. This is super cool, super innovative. Well done.
Thank you. Thank you everyone for
being
coming.
here.
Enjoy the weekend.
Yeah, thanks everyone. We hope to see you at the next one.